The empirical status of cognitive behavioral therapy for eating disorders. Consistent with the current way of classifying eating disorders, the research on their treatment has focused on the particular disorders in isolation. Wilson and colleagues 8 have provided a narrative review of the studies of the treatment of the two specific eating disorders as well as eating disorder NOS, and an authoritative meta-analysis has been conducted by the UK National Institute for Health and Clinical Excellence, NICE. This systematic review is particularly rigorous and, as with all NICE reviews, it forms the basis for evidence-based guidelines for clinical management. The conclusion from the NICE review, and two other recent systematic reviews, is that cognitive behavioral therapy, CBT-BN, is the clear leading treatment for bulimia nervosa in adults. However, this is not to imply that CBT-BN is a panacea, as the original version of the treatment resulted in only fewer than half of the patients who completed treatment making a full and lasting recovery. The new enhanced version of the treatment, CBT-E, appears to be more effective. Interpersonal psychotherapy, IPT, is a potential evidence-based alternative to CBT-BN in patients with bulimia nervosa, and it involves a similar amount of therapeutic contact, but there have been fewer studies of it. 11. IPT takes 8 to 12 months longer than CBT-BN to achieve a comparable effect. Antidepressant medication, for example, fluoxetine at a dose of 60 mg daily, has also been found to have a beneficial effect on binge eating and bulimia nervosa, but not as great as that obtained with CBT-BN, and the long-term effects remain largely untested. Combining CBT-BN with antidepressant medication does not appear to offer any clear advantage over CBT-BN alone. 13. The treatment of adolescents with bulimia nervosa has received relatively little research attention to date. There has been much less research on the treatment of anorexia nervosa. Most of the studies suffer from small sample sizes and some from high rates of attrition. As a result, there is little evidence to support any psychological treatment, at least in adults. In adolescents, the research has focused mainly on family therapy, with the result that the status of CBT in younger patients is unclear. Preliminary findings have been reported from a 3-site study of the use of the enhanced form of CBT, CBT-E, to treat outpatients with anorexia nervosa. This is the largest study of the treatment of anorexia nervosa to date. In brief, it appears that the treatment can be used to treat about 60% of outpatients with the disorder, BMI 15.0 to 17.5, and that in these patients about 60% have a good outcome. Interestingly and importantly, the relapse rate appears low. There is a growing body of research on the treatment of binge eating disorder. This research has been the subject of a recent narrative review and several systematic reviews. The strongest support is for a form of CBT similar to that used to treat BN, CBT-BN. This treatment has been found to have a sustained and marked effect on binge eating, but it has little effect on body weight, which is typically raised in these patients. Arguably, the leading first-line treatment is a form of guided cognitive behavioral self-help, as it is relatively simple to administer and reasonably effective. Until recently, there had been almost no research on the treatment of forms of eating disorder NOS other than binge eating disorder, despite their severity and prevalence. However, recently the first randomized controlled trial of the enhanced form of CBT found that CBT-E was as effective for patients with eating disorder NOS, who were not significantly underweight, BMI greater than 17.5, as it was for patients with bulimia nervosa, with 2/3 of those who completed treatment having a good outcome. In summary, CBT is the treatment of choice for bulimia nervosa and for binge eating disorder, with the best results being obtained with the new enhanced form of the treatment. Recent research provides support for the use of this treatment with patients with eating disorder NOS and those with anorexia nervosa. The remainder of this article provides a description of this transdiagnostic form of CBT. The cognitive behavioral account of eating disorders. Although the DSM-4 classification of eating disorders encourages the view that they are distinct conditions, each requiring their own form of treatment, there are reasons to question this view. Indeed, it has recently been pointed out that what is most striking about the eating disorders is not what distinguishes them but how much they have in common. As noted earlier, they share many clinical features, including the characteristic core psychopathology of eating disorders, the overevaluation of the importance of shape and weight. In addition, longitudinal studies indicate that most patients migrate among diagnoses over time. This temporal movement among diagnostic categories, together with the shared psychopathology, has led to the proposal that there may be limited utility in distinguishing among the disorders, and furthermore that common transdiagnostic mechanisms may be involved in their maintenance. The transdiagnostic cognitive behavioral account of the eating disorders extends the original theory of bulimia nervosa to all eating disorders. According to this theory, the overevaluation of shape and weight and their control is central to the maintenance of all eating disorders. Most of the other clinical features can be understood as resulting directly from this psychopathology. It results in dietary restraint and restriction, preoccupation with thoughts about food and eating, weight and shape, the repeated checking of body shape and weight or its avoidance, and the engaging in extreme methods of weight control. The one feature that is not a direct expression of the core psychopathology is binge eating. This occurs in all cases of bulimia nervosa, many cases of eating disorder NOS, and some cases of anorexia nervosa. The cognitive behavioral account proposes that such episodes are largely the result of attempts to adhere to multiple extreme, and highly specific, dietary rules. The repeated breaking of these rules is almost inevitable, and patients tend to react negatively to such dietary slips, generally viewing them as evidence of their poor self-control. They typically respond by temporarily abandoning their efforts to restrict their eating, with binge eating being the result. This in turn maintains the core psychopathology by intensifying patients' concerns about their ability to control their eating, shape, and weight. It also encourages more dietary restraint, thereby increasing the risk of further binge eating. 3 further processes may also maintain binge eating. First, difficulties in the patient's life and associated mood changes make it difficult to maintain dietary restraint. Second, as binge eating temporarily alleviates negative mood states and distracts patients from their difficulties, it can become a way of coping with such problems. Third, in patients who engage in compensatory purging, the mistaken belief in the effectiveness of vomiting and laxative misuse as a means of weight control results in a major deterrent against binge eating being removed. In patients who are underweight, the physiological and psychological consequences may also contribute to the maintenance of the eating disorder. For example, delayed gastric emptying leads to feelings of fullness even after patients have eaten only modest amounts of food. In addition, the social withdrawal and loss of previous interests prevent patients from being exposed to experiences that might diminish the importance they place on shape and weight. The composite transdiagnostic formulation is shown in Figure 1. This illustrates the core processes that are hypothesized to maintain the full range of eating disorders. When applied to individual patients, its precise form will depend on the psychopathology present. In some patients, most of the processes are in operation, for example, in cases of anorexia nervosa binge purge subtype, but in others only a few are active, for example, in binge eating disorder. Thus, for each patient the formulation is driven by their individual psychopathology rather than their DSM diagnosis. As such, the formulation provides a guide to those processes that need to be addressed in treatment. Fairbairn C.G. Eating Disorders, the Transdiagnostic View and the Cognitive Behavioral Theory. In Fairbairn C.G. Cognitive Behavior Therapy and Eating Disorders. New York, Guilford Press, 2008, pages 7-22. Enhanced Cognitive Behavioral Therapy. Enhanced Cognitive Behavioral Therapy, CBT-E, is based on the transdiagnostic theory outlined earlier and was derived from CBT-BN. It is designed to treat eating disorder psychopathology rather than an eating disorder diagnosis, with its exact form in any particular case depending on an individualized formulation of the processes maintaining the disorder. CBT-E is designed to be delivered on an individual basis to adult patients with any eating disorder of clinical severity who are appropriate to treat on an outpatient basis. It is described as enhanced because it uses a variety of new strategies and procedures to improve outcome, and because it includes modules to address certain obstacles to change that are external to the core eating disorder, namely clinical perfectionism, low self esteem, and interpersonal difficulties.